Good afternoon, everyone. Thanks very much again for the opportunity to speak. Over the next few minutes, I think we'll talk a little bit about how to use a very versatile tool that can be used in many, many different ways in PCI to try to optimize results. So rather than focus on the various spheres that IVUS can be used in, because that's not a 10-minute talk, it's a 10-day symposium. Instead, we'll focus on just how to use IVUS for the fundamentals that we try to use. And maybe within that, I'll try to give you an approach that works for me to remember how to use IVUS to its highest capabilities when stenting. These are my disclosures. So there are many formulae to decide how well you've put in a stent, right? What we try to do is make stents as large as they can, but obviously we don't want to perforate the artery. We don't want to injure the patient. We don't want to dissect beyond the stented segments. So as a result, there isn't a whole lot of agreement around what the right way is, right? There's 14 formulae, some of them say 90% of the distal minimal lumen area, some say 80% of the distal minimal lumen area, some say normalized physiology, some say borderline physiology, who knows? And the fact that there are 14 of these things tells us something. Nobody agrees, right? So the general principle that we can use to follow is pick one formula, whichever one you want, but you're always aiming for the best expanded stent you can get, the biggest minimal stent area you can get, without having to injure the patient, without injuring the patient. So based on the European consensus document a couple of years ago, we aim for a minimal stent area that's 80% of the distal MLA and greater than 5 millimeters squared by IVUS and 4.5 millimeters squared by OCT in the proximal vasculature, okay? This is obviously not a reasonable target in a distal diagonal branch, but it certainly is in the proximal to mid LAD. So here's an approach that I designed some years ago that's a little bit like the MLD max approach, okay? Only it fits with IVUS, okay? It's largely designed for this technology. And these are the questions that you ask yourself to answer. It's called the PEARLS approach, so IVUS PEARLS. P is the plaque composition. So what is it that you see? And while you're recognizing what you see, you're trying to plan how you're going to treat this. Is it calcium? Is it fibrotic plaque? Is it lipidic plaque, etc.? Is it thrombus? So what do you see? P is for plaque composition. E is for EEL to EEL diameter in the distal reference zone. So your adventitial to adventitial diameter, right? Your maximum vessel size at your distal landing zone. We try to land stents in as normal vessel as possible so that this can be an accurate representation of sizing. Right? There are obviously caveats because plaque grows in the media, so the vessel can look very large when in fact you don't necessarily want to measure right across all of that plaque. So try to find yourself a distal landing zone where you can see the EEL on one side and see the EEL on the other side and measure it. A is the arterial lesion length. So how long is your lesion? So on your IVUS pullback, as long as your guide is well engaged and it's not bouncing back and forth, the pullback measurement will actually give you a lesion length, and that's actually very useful information to plan your procedure. R is the reference vessel size proximally, so effectively your EEL to EEL at the proximal edge, where you're going to land your stent. And then L is your landing zone selection, okay? So find a landing zone both proximally and distally that is as close to normal as it can be. Sometimes we can't do that. So if that's the case, then find a place with less than 30% plaque, because that's your most likely zone where you're going to get good stent expansion without an edge dissection, either on the proximal or distal ends. And then finally, S is your stent size selection. This is where the gold is, because a lot of times we don't remember that our stents have very clear confines in which they can be expanded and grown. And so selecting the wrong stent size or the wrong stenting strategy can leave you in a place where you're actually fracturing your proximal end. And that leads to terrible outcomes. One of the most potent risks of stent thrombosis or nidai for restenosis is a stent fracture. So what are the general goals? Largest possible minimal stent area, avoid the risk of excess size, so excess ballooning, avoid gross malapposition. Acute malapposition is no big deal. And then aim to stent normal to normal. Okay, and the best way to determine the information you need for all of these things is by using IVUS, because what it will give you is the precise measurements at each of these areas as well as the plaque composition. So let's use the pearls example and this one example, and well, maybe we can make this interactive. I'll throw this out to the panel, anybody who wants to deal with this. So you've got a 14 millimeter lesion, you've got a 2.7 millimeter distal landing zone, you've got a 3.2 millimeter proximal landing zone with almost no plaque at either end, okay? So having said that, maybe we can use the pearls approach to define a stent strategy for this lesion. Let's start with P, plaque composition. Let's say this is fibrotic plaque. We can make that up, right? So E is your EEL to EEL distally. That's 2.7. A is your arterial lesion length. That's 14 millimeters, right? R is your reference vessel size. So 3.2 millimeters, right? That's the proximal. L is your landing zone. Well, you picked your landing zones, right? You've got the 2.7 millimeter landing zone distally and 3.2 millimeters proximally, because on that L landing zone, you've picked areas with relatively minimal plaque, so almost normal to normal. And then S is your stent size selection. So this is easy, right? This is almost any stent on the market. You can take a 2.5 millimeter, 2.5 by 15 millimeter Zions stent, or a 2.5 by 16 millimeter Synergy stent, or pick one, right? Doesn't matter. Deploy it, and then you post-dilate using a 2.5 millimeter non-compliant balloon at high pressures at the distal end, and a 3.0 millimeter non-compliant balloon at the proximal end. The beauty with the IVUS is it can also show you where your branches are. And so you can line up, by fluoroscopically co-registering your IVUS, you can line up precisely where you want to post-dilate so that you don't oversize a segment of negative remodeling and you don't undersize a place where you actually need to expand your stent. So that's the pearls approach in action, okay? And this is all of that stuff, right? This is all of the details that we just went through very intuitively. So you stent it with a 2.5, take it up with a 3.0. So let's try this second example. This is a long lesion now with some size disparity. You have a 3.0 balloon, you have a 3.0 distal landing zone, you have a 4.5 proximal landing zone as you've selected. So let's pearls this again. Let's say once again this is fibrotic plaque or calcific plaque, doesn't matter. We're going to pick what we're going to pick to fix it. Then your EEL to EEL diameter distally is 3.0 millimeters. A was your arterial lesion length, so that's 36 millimeters, right? We've measured it using the IVUS. R is your reference vessel size, so proximally you're at 4.5 millimeters. L is your landing zone assessment. Are we satisfied with these landing zones? Is everybody happy with these? We've got a reasonably normal looking vessel where we're landing the stent. So now let's select a stent size. That's all of the information you need to figure out what stent you want to put in. So do we have a stent that can go from 3.0 to 4.5? Does that exist? Not really, right? The Synergy goes from 3.0 to 4.25. Resolute Onyx goes 3.0 to about the same. Your Zions Expedition 3.0 platform goes to 3.75. So this is a situation where you can use one of two strategies. You can either take a 3.5 millimeter stent, which is where the stent sizing platform changes, okay, and under deploy a 3.5 millimeter back to your landing zone, so under deploy it at 8 atmospheres. This is sort of what we discussed with Professor Mir Jamal while he was doing his live case. And then you can selectively post-dilate, leaving one strut from the distal end with a 3.0 millimeter balloon distally, a 3.5 in the middle, and a 4.0 to high pressures proximally. That'll take you to 4.2, 4.25. That's pretty good. Another option is to take a short 3 millimeter stent and overlap it with a short 4 millimeter stent. So 2.18s, for example, or 1.20 and 1.18. Because then the 3.0 will easily go to 3.5, but your 4.0, which is capable of going to 5.75, will take a 4.5 non-compliant balloon at the proximal end, and that's truly the largest you can make it. Personally, I don't think there's an appreciable difference between 4.3 millimeters and 4.5 millimeters, so I would stick with the safer of the two strategies, to be honest. But it depends on where you are, right? If you're one strut outside of the left main and you really want that, to make that big and trumpet it, you may choose the second strategy. It's a very reasonable thing to do. So these are the details that you need to know, right? The devil is in the details. And this is an old chart. Don't use this. Find a new chart. I didn't have quick access to the newest charts, but these things have changed, right? Like the 4.0 millimeter Synergy, for example, will go to 5.75, right? So the Resolute Onyxes will go up to 575 as well, right? Your Resolute Onyx goes, your Megatrons go all the way up to 6, right? So these are the details. These are the things you really do need to know, because this is what makes you good at PCI. Remember we talked about square peg into square hole, round peg into round hole. So this is about selecting just the right tool for what you need. So this is what we might choose to do in this sort of a scenario, because we know the expansion limits, right? Take a 3.0, put it to 425, or take a 3.5 all the way back and go up to 425 there. Okay? So what about example 3? So this is what your vessel looks like. So now you have a terrible vessel, right? You have a nice proximal landing zone, but you have an unhealthy looking distal landing zone. How do you manage this? It's the same way as everything else, right? There's no magic here. It's all very easy. P, standard lipidic plaque or standard soft plaque. So we balloon it open with a compliant balloon. It opens, you're ready to stent, right? EEL to EEL diameter. You can't really find a clear EEL in the middle of the lesion, right? So you have to move all the way out here. But going way out here means the vessel gets very small. So you have to select a landing zone that's got some disease in it. So EEL to EEL still remains your 2.75. But when you've got more than 30% at your landing zone, 30% plaque at your landing zone, now you're stenting plaque to plaque, okay? Because you don't want to dissect that plaque. So for a 275 landing zone that may be EEL to EEL, the plaque diameter might be 225. So then you're going to choose a 225 distal edge stent and then post-dilate everything but the last strut up so that you can maximize the size. Your goal is a minimal stent area that's 80% of the distal minimal lumen area, right? It's the same goal. And so if you're landing in disease, you've got to be careful when you land to ensure that you don't dissect that plaque. Even if you land conservatively with sizing at your distal strut, you can IVUS that, prove there's no dissection, and then post-dilate proximally aggressively. So going back to pearls, plaque we talked about, your distal EEL to EEL we talked about, A is your lesion length, right? So let's call this lesion length whatever you want to call it. 18 millimeters. Let's say it's 18. Okay? R is your reference vessel size. So what do you think about the proximal landing zone? Proximal landing zone is nice, right? There's less than 30% plaque there. And that, once again, is what your IVUS is telling you. So you can IVUS that, prove that that's a healthy landing zone, and be very comfortable putting a 3.5 stent in. So R is your reference vessel size. L is your landing zone. So you've selected the distal one in disease because you don't really have a choice, right? You don't have a great place to put this stent. Proximally, you're much better off. Proximally, you've got a normal landing zone. So with your IVUS, you can very precisely select the stent that you want. What kind of stent would we want to put here? Let's say that instead of 2.75, it's 2.5 in the distal edge and 3.5 in the proximal edge. Now all you need is a 2.5 stent that's capable of going up to 3.5. Right? So your media to media might be 2.75 or 2.95, but your lumen is 2.5. So you're going to select maybe a Resolute Onyx stent, right? Where the 2.5 will go up to 3.5 without breaking a sweat. And then distally, you'll post-dilate with a 2.5 millimeter balloon, leaving the last strut behind, gradedly post-dilate through the stent, and then take a big 3.5 millimeter balloon at the proximal edge and go to town. I post-dilate most stuff between 20 and 24 atmospheres. And not a problem. Sometimes higher. Not worried about perforation because I know from the IVUS exactly what the vessel size is. Precisely what the plaque composition is. I don't have to be worried about it. So this is what we did. Let's talk about unhealthy proximal landing zone. So this is fun now. Nobody likes these, right? And this is the same principle. So I won't, just in the interest of time, I won't belabor all of this. But you've identified all of the things that you need to identify by doing an IVUS. You know what the plaque composition is, so you'll treat that appropriately. That's a separate section of discussion based on the IVUS findings. We talked a little bit about it in the other room yesterday and today, which was about how to handle calcium, for example, and using what tool. Your distal edge is 3 millimeters, right, from EEL to EEL. Your lesion length is 30 millimeters. Your reference vessel landing zone is where your problem is. Because do you see proximally here, is this a healthy landing zone? Not so much, right? There's more than 30% plaque here. So now you're stuck a little bit, where you're going to have to stent lumen to lumen, plaque to plaque at this landing zone. An alternative is that you extend your stent further back to a normal landing zone. So let's say that that was the ostium of the LAD, Do you want to nail the ostium of the LAD where there's a bunch of plaque? Probably not. This is your classical case where you would cross over and come back into the left main into a normal landing zone. Or if, let's say, that was the left main, this is the one where you stent right back to the ostium and you hang a strut back. Because then you don't have to worry about proximal landing zones and 30% plaque versus EEL to EL diameter, right? That is probably the one exception to the usual rule of lumen to lumen stenting in the setting of plaque. Because your proximal landing zone is what governs your inflow. You want that to be as big as you can. And so force yourself as much as you can to go normal to normal, okay? And then stent size selection. So if you've got a stent size selection here, let's say that this is the mid-LAD, distal to mid-LAD, where you're not gonna go all the way back to the left main. What you want is a 3.0 millimeter landing zone distally, that's the healthy part, but you can only come up to 3.5 proximally. So as I said, find a better proximal landing zone. If you can't find one, pick a stent that goes from 3.5 to 4.5 and post-dilate the whole stent based on the EEL to EEL, but then leave one strut at the proximal edge and go ahead and post-dilate so that you don't dissect the proximal plaque. And then confirm that when you do the IVUS again, right? We do one pre and one post. The beauty of this approach is on your single IVUS, you get everything, all of the information you need, right? And that single information, that single run allows you to ask for every balloon and every stent you'll need, and then allows you to do one post run in the IVUS. So healthy landing zones will usually accept a 1-to-1 media to media true vessel size. Unhealthy landing zones require either the selection of a better landing zone or an extension of your stent to a normal landing zone so that you can really post-dilate. And when post-dilating heavy plaque burden, downsize just a touch or leave the proximal stent strut unpost-dilated. And just very quickly, I don't know why it skipped this one, but I'm going to give you just this two quick thoughts about this last one. Sometimes we get negative remodeling in the middle of the vessel, right? We've all seen that, right? And this is where the IVUS is absolutely critical. This is when perforations happen and where the intravascular imaging really tells you. Whether it's IVUS or OCT, doesn't matter. In the middle here, you have a 2.3 millimeter segment of vessel, but your distal is 2.5 and your proximal is 4. So this is the one where you have to overlap two stents. Because if you try to take one stent from 2.5 to 4, you're going to break the stent platform. And if you try to systematically post-dilate through the whole thing, you're going to break the stent platform, you're going to break the vessel. So take a 2.5 to a 3.5 stent in the distal edge, and then overlap that with a 3.5 stent that goes all the way up to the proximal. Do not try to post-dilate this to 5.25 millimeters here. That's where you've got an aneurysmal segment and you just deal. If you try to post-dilate there, that's where you get perforations. Okay? So the Pearls approach, which I'll throw up here in case anybody didn't get a picture of it and wants to take a picture of it. The Pearls approach is a simple, systematic way of taking a moment to understand what you're looking at on your IVUS and how you can then specifically use the information that the IVUS gives you to optimize your stent implant. Thanks very much for your time and attention.